Okay, welcome to red blood cells. So this is something you've probably already gone over in your regular anatomy and physiology class. So we're just going to just cover again some of the basic things here, especially as it relates to carrying of oxygen and some of the things that can really affect you. So we talked about before how the lungs can do the best they can. They do what they can to get oxygen into the bloodstream, but if there's something wrong going on in the bloodstream, like we don't have enough red blood cells, we have anemia, or we have dysfunctional blood cells, then we're not going to still be able to get oxygen to the rest of the body because the blood can't carry it. And so not only do we need good ventilation, but we also need good perfusion as well going through the alveolar capillary membrane. If there's hardly any red blood cells, or if the red blood cells are in an abnormal shape, or the red blood cells are dysfunctional for some reason or another, we're going to have a hard time getting oxygen to the heart, getting oxygen to the brain, getting oxygen to the kidneys. And this is a very bad thing. So let's talk about the red blood cells, and not only how they carry oxygen, and not only when we're looking at carrying the oxygen, but also what it means when we look at PaO2. So now we're talking about P little a. O2. So that's how much pressure of oxygen there is in the bloodstream. And then there's P big AO2, which remember was how much oxygen is in the alveoli. So when we're talking about the bloodstream specifically, we're going to be talking about P little AO2. So remember, oxygen, when it's not bound to a red blood cell, or a hemoglobin molecule more specifically, when it's not bound, it does exert a partial pressure, and that's PaO2. So this pressure is not bound, it's just floating around as a pressure in the plasma. So when it's floating around in the plasma, it exerts a pressure, and we need a pressure in there. Because remember, when we go to the tissues, we need a higher PaO2 in the bloodstream. When we head to the leg muscle, for instance, we need a higher PaO2 in the arterial than we do in the muscle. So that way we have a gradient of sending oxygen from inside the vasculature to into the tissue. So we need that pressure gradient. If someone has a very, very low PaO2, their pressure gradient for delivering oxygen to their tissues is going to be very low. So you'll see it even in critical care medicine, where we'll look at someone's PaO2. PaO2, if it's less than 55 for a lot of studies out there as of recording this, 55 millimeters of mercury is usually a critical thing for a lot of these places, and if we can keep the PaO2 above 60, that would be ideal, but anything 55 or less tends to be very critical. In other words, we're not delivering enough oxygen to our brain, we're not delivering enough oxygen to our kidneys, we're not delivering enough oxygen to our vital organs, including our heart muscle, right, our myocardium. So PaO2, even though it may not carry a lot of oxygen as it being just dissolved in the plasma, it still plays an important role in starting the cascade to pull oxygen off of the hemoglobin molecule, as well, as we will talk about more in the oxyhemoglobin dissociation curve lecture. Now that one's going to be a lot of fun, so you're just going to have to tune in for that one when we get that one going. So when we're looking at this, we're going to look at two ways oxygen is traveled in the bloodstream. So first way, we've already looked at here, it's just dissolved in the plasma, and this carries very little amount of oxygen, 0.003 mLs, right? It's crazy how little oxygen is carried in the plasma, but it plays a very important role when it comes to starting the cascade to getting oxygen off the hemoglobin molecule as well. It's almost like the person that starts a slow clap, right? That person, one person starting that slow clap, and then everybody else joins in, right? We need something to start it off, right? We need someone to start it, and that PO2 plays a key role in oxygen getting on to the getting into the bloodstream, as well as oxygen getting out of the bloodstream. So PO2 is what's in the plasma. The other thing that carries oxygen is your good friend here, hemoglobin molecule. hemoglobin molecule, when we have oxygen, let's just do blue. We have oxygen, and of course you guys have already gone over this. We have oxygen, and when the oxygen goes into the bloodstream, it can either stay in the bloodstream as PaO2, or what it most likely will do is attach itself to a hemoglobin molecule. And when it does this, it's almost like it creates its own new thing, because now it actually changes the shape and the form of the hemoglobin molecule. It's pretty crazy. So it goes from being tight and loose. So when we're talking about this, we actually change the shape. It changes the formation of the hemoglobin molecule, and because the oxygen is now bound to the hemoglobin, it actually does not exert a partial pressure anymore. In other words, it won't factor in. So how much oxygen is carried on the red blood cell does not relate to how much is in the PaO2. Right? So this is going to be very separate. So this PaO2 is just what's in the plasma. It is not also reflecting how much is attached to the hemoglobin molecule. I'll say that again. The PaO2 is just what is the pressure of oxygen in the plasma. It does not also represent how much is on the hemoglobin molecule. So what does that mean? Most of the oxygen that's in your bloodstream that's going to your vital organs right now is being carried on the hemoglobin molecule in your red blood cell. Okay, so that's what's doing most of the work. So this one, since it does not exert a partial pressure, the one that's on your hemoglobin molecule, this is where we look at something called saturation. So when we put a pulse oximeter on someone, which we'll talk about in this lecture a little bit, we're looking at saturation, or how saturated that hemoglobin molecule is with oxygen. Let's say your saturation's only 75% saturated. Well, that's not very good, but that means one of these oxygen molecules is not there. So you have 3 out of 4 oxygen molecules that it's reading that's being carried. That fourth one's not there, okay? So saturation, when we look at someone's oxygen saturation level, is looking at how saturated the hemoglobin molecule specifically is with oxygen. So we look at both PaO2, right? We're talking about little AO2, right? What's in the plasma. And we look at saturation to look at how well someone's body is receiving or delivering oxygen. Okay, so when we look in clinical medicine, we're going to talk about PaO2s, and we're also going to talk about SaO2s, those saturation levels. Right? So when we're looking at pulse oximetry, that's a non-invasive. We're using a laser to refract and to get light to bounce off to tell us if hemoglobin is saturated or not. We could also draw a blood sample from the artery. It's called an arterial blood gas. And when we draw that arterial blood gas, we can look at saturation directly with our machine. So we can go to the lab, and the lab will run the sample, or if you're at a hospital where the RTs run the samples, you will run the ABG sample, and you'll actually see the saturation and the PaO2. So what's important here? We need to make sure that our PaO2, so what's in the plasma, and our saturation, what's on the hemoglobin molecule, both have an adequate level. If there's an imbalance in this relationship, then our ability to get oxygen to our tissues decreases. Both of these are equally important, even though saturation carries most of the oxygen in your bloodstream. You need the PaO2 to start the cascade. It's what starts the party. It's what starts the slow clap, right? It's what does the beginning and end of it. So you need both the PaO2 for your pressure gradient as well as saturation for carrying the bulk of the oxygen. So it's going to be important to look at both PaO2 and saturation. And when we look at red blood cells, if they're not functioning well, it will affect PaO2 and saturation. Now let's say someone's anemic. before we leave this slide, let's say someone's anemic. They don't have very many red blood cells going on. So if they don't have very many red blood cells, their saturations might be great. But if they don't have enough red blood cells, the overall amount of oxygen they can carry is still very poor because there's less of them. So yes, their saturation looks great, their PaO2 looks great, but overall, they're not able to carry near as much oxygen as if they had a normal red blood cell or a normal hemoglobin level, right? So when we're looking at these, there's a lot that factors into the red blood cells, the plasma, and how that affects our patients and how that affects the organ function of our patients as well. So let's get into just the development of red blood cells. So they're mainly produced from bone marrow. They can also be produced in the liver and spleen as well if there's a lot of stress for it. So if you have a patient, you're working in trauma medicine, right? And you have a patient that had a bleed out or losing a massive amount of blood or internal bleeding, their body has compensatory mechanisms that can allow them to actually produce more red blood cells more than just in the bone marrow. Your liver and spleen can also help in this process. So that's a great compensatory mechanism. So the spleen and the liver can also do it, but in general, it's your bone marrow, right? And you remember talking about this in A&P, I'm sure. The stem cell, it goes from being a stem cell to a multipotent stem cell to erythroblast to a full-blown red blood cell. So that's sort of that life cycle. It can take about a couple of days, like 3 to 4 days, to go from erythroblast to that red blood cell. Once the red blood cells mature, it lives roughly around 120 days. So let's look at this picture here. So this is one way your kidneys can actually help you if your oxygen levels are low in your body. So your kidneys are a very highly metabolic organ, right? They have a very important job, right? They filter your bloodstream, they help control your vascular volume, they help with your blood pressure regulation. There's so many important things that your kidneys do. And so your kidneys, being a very highly metabolic organ, right, very oxygen hungry organ, that's why if someone has oxygen problems, their kidneys tend to shut down. This is one of the reasons why I'm a very strong proponent of respiratory therapists paying attention to someone's renal function, right? What are their labs looking like for renals? What's their urine output looking like? What's their eyes and nose, their input and output? I want to know how their kidneys are functioning, because if their kidneys are starting to decline in function and they had no previous history of renal dysfunction, then that could be a sign that their oxygen levels are very low to their kidneys, and then that's what's causing the kidneys to be dysfunctional. Now, when your kidneys start to fail, a lot of other things start to fail too, right? So this is going to be a very important thing to pay attention to, especially if you want to work in critical care medicine, all right? So renal function, very, very key. So that's why I like to look at it, because that could be a sign or an indicator that the oxygen levels are no longer adequate in my patient's bloodstreams, and I may have to draw another arterial blood gas to check for any issues that could be causing that as well. So the kidneys can actually help us out. If they detect a reduced oxygen carrying capacity of the blood, right? So they're no longer getting the oxygen that they need, they're going to respond by secreting erythropoietin, or EPO. Now, if you may have heard of this before, especially if you're sort of into the sports world out there, erythropoietin is something that some athletes can use to what they call blood dope. And so they have a thing where they can either auto-transfuse, where they donate blood ultimately to themselves right before they race. So they have a ton of red blood cells, so they can carry a lot of oxygen and perform really well without going into fatigue, right? Because now they're going to be able to carry a lot of oxygen. Their muscles are not going to go into anaerobic metabolism near as quick as someone that doesn't have as many red blood cells. Or they can do something like erythropoietin. And erythropoietin stimulates your erythropoiesis by the bone marrow. In other words, it's going to tell your body, hey, make more red blood cells. We're not getting enough oxygen, so if I make more red blood cells, that means I can carry more blood to the lungs, which means once I carry more blood to the lungs, I can actually carry more oxygen to my tissues. In other words, I'm creating this erythropoietin to create red blood cells to give me more oxygen. So that's another way they used to do it, is some of these athletes would do erythropoietin or EPO. And it's still used as a treatment for people that have anemia issues as well, not just for cheating in sports, especially endurance sports, but it was designed that it's something your body naturally makes to stimulate your body to make more red blood cells so you can get more oxygen ultimately to your tissues. So once you go into erythropoiesis, it will add more erythrocytes, right, to increase more oxygen carrying capacity of the blood. So the more red blood cells you have, the more capacity or the more ability you have to carry oxygen, right? There's more cars on a train. If you want to think about this like a train, I don't know if that's a good analogy for you, but if you're looking to carry a bunch of cargo on a train, if you only have 3 cars to carry the cargo, then they're going to be at high capacity, but you're still not going to be able to carry a lot of cargo overall. But now I give you the same train, but now I give you 30 cars to carry all your cargo. Well, that means your capacity to carry more cargo just increased greatly. So when we're looking at this, the more red blood cells you have, the more ability you have to carry oxygen to your tissues. So that's why when we have patients that have bleed outs, when you have patients with internal bleeding, GI bleeds, external trauma bleeds, you name it, it's going to be a big issue keeping their oxygen levels up in their body. No matter how much oxygen I give them up in this alveoli, right, I can give them tons of oxygen up here and their diffusion could be perfect, but if they have hardly any red blood cells going past there, their ability to get oxygen to the tissues like the brain, the heart, the kidneys, is going to be very, very hard. And so their oxygen levels will still be low. Their PO2 levels will still be very, very low. And they'll be going into organ failure, right? And we'll even see this with patients that have carbon monoxide poisoning. Carbon monoxide poisoning is where the carbon monoxide attaches itself to the hemoglobin molecule before oxygen ever can. And what happens there is their oxygen levels look fine because their tissues aren't being able to pick it up. So whatever oxygen's on the hemoglobin molecule stays there. It won't go to the tissues. So your hemoglobin molecule, what oxygen it does have, it holds on to it, because it's such a precious commodity, right? And so your tissues end up being robbed of oxygen. So their saturations, their hemoglobin saturations of oxygen, their pressure of oxygen in their bloodstream, both of those look fine, but this patient will randomly start going into renal failure. They'll start going into multi-organ system failure. They'll start to go into delirium with their brain function, right? They'll start to throw arrhythmias on their EKG rhythm because they're being robbed of oxygen at the tissue level. And so those organs are starting to fail. So that's something that we might even see with carbon monoxide poisoning, right? So this all has to do with how it attaches in looking at how important our red blood cells are here. So no matter how much oxygen you give this patient, no matter how much pressure, no matter how much FiO2, no matter how much CO2 you get rid of, if there's something like carbon monoxide or if they're anemic, you're still going to have trouble delivering oxygen to their tissues for adequate body function, right? For that internal respiration is decreased. Okay, so erythropoietin, your kidneys are very, very friendly in the fact that they might see a decrease in oxygen, and as long as you have healthy kidneys, you might stimulate the kidneys to actually help your body increase the carrying capacity. So what would we do in the meantime? Someone lost a lot of blood in a trauma, and where their oxygen levels are very, very low, their PO2 is very low, their organs are starting to shut down. Well, what's a good fix for that patient in the meantime? What's a good therapy for that patient in the meantime? Well, that would be a transfusion, right? So we do have to be careful of transfusion-related lung injuries. That's called a TRALI. transfusion-related acute lung injury. As well, but what we need to be able to carry oxygen to those tissues like the heart, the brain, and the kidneys to keep those organs going if we want to keep our patient alive. And so that's going to be very important. So the kidneys are going to help, but in the meantime, we might have to give them some of our own packed red blood cells. Hopefully that helps, right? Helps you sort of see the vitality of the red blood cell and the pressure as we're going through this. So the hemoglobin molecule is a protein that transports oxygen transports molecules of oxygen to your tissues as well as CO2 away from your tissues. So that's why it's important when we're looking at the hemoglobin molecule, not only to look at, hey, our oxygen delivery, if our hemoglobin level is low, our oxygen delivery will also be low, but also our CO2 elimination from the body will also be low, right? Because what we have here is the ability for this oxygen, once it makes its way to the tissue, it gets rid of the oxygen at the tissues. Well, now the hemoglobin molecule is open, it changes shape, and now it has the ability to carry something with it as it goes back to the lungs. Well, one of the things that it can carry with it is CO2. So that means if someone's hemoglobin level is low, not only will their oxygen levels be low, but their CO2 levels could also be high. So what would that mean to your pH of your bloodstream? If your oxygen levels are low, your CO2 levels are high, your pH would start to decrease. You're going to become more acidic, right? And so this is where your body can start going into failure as well. Your brain, you have altered mental status. Your brain can have altered mental status, your kidneys can start to shut down, your liver starts to shut down, your organs start to fail. Especially just like even plants, right? If their pH is way off, they'll start to die, right? Same thing here. If your pH as a human starts to be way off, you start to go into failure. So this is not only important for oxygen delivery, but also for elimination of acid from your system, that CO2, that carbonic acid from your system. So there are 4 globin protein chains with an iron in the center, Fe. Remember Fe from the periodic table. So when we're looking at this, the Fe is +2, so that's sort of that last thing down there. And your oxygen is -2, so they have that electrical the electrical bond that they like to form together. So as long as we have good ferrous oxygen, as long as we have our ferrous, right, as long as that molecule is ferrous, then we'll be able to attract oxygen. Now there is a case out there where your iron molecule can then go from being ferrous, where it attracts oxygen, to being ferric, where it does not attract oxygen. And this is something you might encounter in your practice. It's actually called methemoglobin anemia. Long word, but it can actually happen if we give someone nitrous dioxide by accident, or if we give someone too much lidocaine, like lidocaine toxicity. There are other situations that can also cause methemoglobin anemia, and we actually have to treat that differently, right? And that's in order to get the oxygen to bind with it again, we have to turn it back to being ferrous again. Well, that's important because if it's not ferrous, we're not going to be able to carry oxygen. Their blood literally turns brown. So we'll go to draw on our arterial blood gas, and you'll see this sort of chocolate-colored blood come into your syringe. That's one of the signs that you might have a methemoglobin anemia. In other words, the iron went from being ferrous, where it attracted oxygen, to now being ferric, where it does not attract the oxygen molecule, which is not good because then you're not able to carry oxygen to your tissues, right? You'll go into organ failure, go into heart failure, go into altered mental status for sure. Okay, so when we're looking at the globins, the hemoglobin molecule itself, it has on an adult, and that's why I have HGB hemoglobin, A, which I think of it mentally as adult, has 2 alpha and 2 beta globin protein chains. Great. That's how it normally works. That's what you have going on in your system right now. Hemoglobin fetal, so HGBF, has 2 alpha, but instead of beta, it has 2 gamma globins. The way I remember this when I was in school, I remember that little kids like to call their grandma gamma sometimes. That's how I remembered it, but, pick your own way of looking at these things. 2 alpha and 2 gamma globin protein chains. Well, why? Why is there a difference? Until you're about 3 to 6 months old, you have what's called fetal hemoglobin. Okay, I was looking at this. I was looking at sort of how and why things are the way they are. It's very interesting. But when we're looking at this, why? Why do you have fetal hemoglobin? Why does fetal hemoglobin differ? Well, when you were in utero, your mom's blood volume increased usually by 50 to double, right? Your mom's blood volume increased quite a bit to help carry more oxygen. However, not enough to keep your body developing and all that stuff. So what happens is in utero, your bloodstream, right, as a fetus, your bloodstream actually became more efficient at carrying and using oxygen. So that gamma globin protein chain changes the ability of your body to carry oxygen. In other words, it makes you more efficient at lower oxygen levels. So that means you could have a PaO2 of 29 millimeters of mercury compared to 79 millimeters of mercury, and you could still have adequate oxygen delivery to your tissues to develop and grow. You could still have adequate oxygen delivered to your brain, to your kidneys, to your whole body that's growing and developing in utero. And so that gamma globin protein change actually changes the ability or how much oxygen can be carried on a lower PO2. At a lower pressure, I can still carry a whole heck of a lot of oxygen and still develop and grow. So until a baby is about 3 to 6 months old, they still have fetal hemoglobin on board. Isn't that crazy? So when you work NICU, if you do work in neonatal intensive care, we actually are okay with lower PaO2, little PaO2 levels on these little babies because they still have fetal hemoglobin going on. That means their body's still very efficient at carrying oxygen at lower pressures, right? At lower PaO2s, their body can still adequately deliver oxygen. Isn't that crazy? It's awesome. I think it's pretty cool. All right, so when we're looking at this, there is a case, right, we talked about where your iron is going to be one of the big things that helps attract oxygen. There's something called methemoglobin anemia. And methemoglobin anemia is a long word, but this is where the iron, instead of being ferrous, where it attracts oxygen, it goes from being ferrous to being ferric, where it does not attract oxygen. The way I remembered ferrous, where it attracted, and ferric, where it does not attract it. I remember ick is ew, is like get away from me, I don't want to see you anymore type thing, or that's ew, that's gross, like ick, right? Icky. That's where the hemoglobin molecule wants nothing to do with the oxygen, and this is something that can happen in your practice, right? There was a case in a hospital down south. I will not name it, but they gave a patient a lidocaine nebulizer to numb down their airways for a bronchoscopy. And the patient got a lot of lidocaine, somehow got into their bloodstream where they were sensitive to it. And this is something that you will be doing. The patient went into methemoglobin anemia. And one of the classic signs of this, because the oxygen molecule is no longer attaching to the hemoglobin, when you go to draw the arterial blood gas, it actually comes out as a chocolate brown color. So, and that's even a board question, right? They'll look at it and be like, hey, you draw blood, it's a brown chocolate color. What condition is this? And you'll be like, oh, Derek, I remember Derek saying this is a methemoglobin anemia, right? So this is where the oxygen is no longer attaching or being attracted to the iron in the hemoglobin, right? And I have some more pictures in here of that. But that's the important thing there. It goes from being ferrous to being ferric. And so how do we treat that? What do we do? Well, in the meantime, we're going to give them a lot of oxygen. So you're going to give them as much high FiO2 as you possibly can. And then usually the stain that we use for the Z-Hill-Nelson, that methylene blue, that Z-Hill-Nelson stain, the methylene blue, if given IV, right, if we gave it IV, can actually help neutralize the methemoglobinemia and turn it from being ferric back to being ferrous. And I always remember ferrous as Ferris Bueller, and it was a very attractive thing, all that stuff, right? So this is actually something you may encounter out there. It can also happen with nitrous. If a patient somehow gets exposed to nitrous, not N2O, not NO2, but N2O. That's like if we have nitric oxide that gets exposed or is stagnant to oxygen, then it actually might turn into N2O or NO2, sorry, and it can actually cause this as well. So we got to be aware of things like that as well. That can happen. So a lot of stuff going on here. Hopefully you get that 3 to 6 months, right? You still have that fetal hemoglobin going on. Your body's doing that. It just means those babies are very efficient. So you'll see their PO2s at like 55, and the care team isn't worried near as much, right? Their saturations will be at 88 to 93% in that area, and you'll be okay with that because in utero, that baby is premature most likely when you're working NICU, and they were pretty much simulating them still being in utero to help them grow and all that stuff. We don't want to give them too much oxygen. There's a lot of bad things that can go along with that, especially in the neonates. They're more prone to oxygen injury and oxygen toxicity. But we'll get there when we get to that class. All right, so this is a better picture. I like this picture a little bit better. You may not, but I think it's kind of cool to actually see the alpha and the beta chain, right? So this is HbA, this is adult hemoglobin, and then you can sort of see the iron and the hemi group in there, and you see how there's 4 of those, right? So these are all on the red blood cells. So that's why if you don't have many red blood cells, your hemoglobin will be low. If you have a lot of red blood cells, you might have higher hemoglobin, right? So this is how it attaches itself, or where the oxygen binding sites will be in that protein chain. So this is an alpha and beta. This would be a adult hemoglobin chain. So for every hemoglobin molecule, we can attach 4 oxygens, right? Because how many of these irons are there? Right, 1, 2, 3, 4. So every one of them can carry 4 oxygen molecules. Now, I'm not going to talk about CO2 yet. We will have a time, way different lecture, where I'll talk a lot more about CO2 transportation as well. All right, this is another picture that I like looking at. So these are just different ways. It's okay if some of these pictures, like if this picture here does not connect with you if you don't have a chemistry background, that's okay. Right, but if you do have that background and this helps you connect to the information better, that's why I have it in here. So this is all about you connecting to the material. So I like to try to bring in different ways of looking at it, just like having different worksheets and different wording and scenarios and stuff. Right, so this is what we're ultimately looking at, the oxygen molecule connecting to it, and we have that iron center that's in there, and then ultimately we can carry 4 oxygen molecules with the hemi group ultimately. So this will only carry 1 because it's only on the 1 iron molecule as well. So this is what you're looking at down here on the red blood cell. The red blood cell contains several 100,000 hemoglobin molecules, all of which can transport oxygen and CO2. Remember, not only does it transport oxygen, it also transports CO2 as well, right? So both are just as important. So the oxygen molecule will bind to the hemi group. That's what you're seeing here in the picture, right? So it binds to that hemi group, which has the iron in the center, right? That's why we have that picture up there in the corner. So it binds to that hemi group, which has the iron in the center. And then once it does this, right, once it binds to the hemoglobin molecule itself, remember, oxygen that's bound to the red blood cell or bound to the hemoglobin does not exert pressure. So no pressure, right? It does not exert pressure once it attaches to the hemoglobin molecule. So therefore, your PaO2, P little AO2 is only how much pressure of oxygen there is in the plasma. And your saturation is how much oxygen there is being carried in your red blood cell. So remember that. Once it's on the molecule itself, it no longer exerts a partial pressure. Okay. Hemoglobin, one hemoglobin, this is going to be a very important number to remember. In fact, you're going to use this in a lot of calculations. So let's start it here. So the hemoglobin, one hemoglobin can bind 1.34 milliliters of oxygen per gram of hemoglobin. Okay, what does that mean? Okay, so here I'm going to draw a room. Okay. So in this room, I can hold, I don't know, 6 people, okay? So I have 6 people hanging out in this room. This, if I'm a fire marshal, I could go in and say this room is so small that the maximum occupancy, in other words, the most amount of people in this room is 6 people. Okay, what does this have to do with this, Derek? So when we're looking at hemoglobin, for every gram of hemoglobin, so that's the weight of the hemoglobin, right? That's a unit of mass. For every gram of hemoglobin, its maximum carrying capacity, or how much volume of oxygen can be carried on it, is 1.34 milliliters of oxygen per gram of hemoglobin. So if I want to figure out how much oxygen someone can carry, what's their maximum carrying capacity, what's the most amount of oxygen I can fit into their bloodstream, well, I can take their hemoglobin level. Let's just say their hemoglobin level is 15 grams. And I can take that times 1.34. And what I would be doing here by multiplying their gram of hemoglobin by 1.34 is finding out of this 15 grams of hemoglobin, how many milliliters of oxygen I can fit onto their red blood cells right now. So looking at this, if I do this, if I just multiply these together, I'm going to get somewhere around 20.1, and this will be grams percent. So when we're looking at this, I can carry 20 milliliters of oxygen for this 15 grams of hemoglobin. I can carry 20 milliliters of oxygen with this hemoglobin level. That's my maximum carrying capacity, right? That's how much my bloodstream can actually carry if I have 15 grams of hemoglobin. Right? So this is part of an equation you will be doing later. I'm going to ask you, hey, what's your maximum capacity? How many, or what's your volume of oxygen that you could carry right now? Right? In a most perfect situation, you can get every bit of oxygen into your bloodstream from your alveoli. Every bit of it can get into your bloodstream. What's the most amount of oxygen you can carry? Right? And so all you're going to do is take their hemoglobin level times 1.34, and that tells you, man, that's as much as they're able to carry. Right? So that's the sort of a beginning to one of the equations that we'll be talking about there. But that 1.34 is a carrying capacity, or in an ideal situation, how much oxygen in volume are you able to carry for your hemoglobin level. So this tells you, if you're looking at a patient and their oxygen levels are really, really low, and we draw an arterial blood sample, and we see that their hemoglobin level, let's say, is at 8. their ability to carry oxygen is very, very low, right? So if we did 8 times 1, right, if we did the 8 times 1.34, we would only get a answer of about 10, right? A little over 10, 10.7, right? We'd get almost 11. So our ability to carry oxygen would be very, very low because their patient's anemic. They don't have enough red blood cells. They don't have enough hemoglobin to carry the oxygen. And that can tell us, hey, that's why the patient's body is shutting down. That's why we're having such poor mentation. That's why we're having abnormal EKG patterns, and that's why their urine output is low, and that's why their renal function, their BUN and creatinine are going up higher, and that's why their AST, ALT, their liver function is increasing, because our organs don't have enough oxygen because we don't have enough hemoglobin. We don't have enough red blood cells. All right, so I know that's a lot, but you can watch this over again. But 1.34 is how much milliliters in volume of oxygen your body can carry per gram of hemoglobin. This is an important thing to know, right? Because we can give this patient as much oxygen as we want to, and that's what we'll do in the meantime. But if we don't get them blood, if we don't get them red blood cells, it's not going to help, right? It's not a fix, right? And their body needs to get those red blood cells to fix what's going on. When hemoglobin transports gases, if it is transporting oxygen, it's termed, so these are like terms or definitions, as oxyhemoglobin. All right, that makes sense, right? There's oxygen bound to it. It's called oxyhemoglobin. If once it's been delivered to the tissues, and that's what you see over here, once the oxygen has been delivered to the tissues, all right, we're delivering oxygen, the hemoglobin molecule changes shape, and then it's able to accept carbon dioxide, right? So once it's able to change shape, it accepts carbon dioxide, and as it accepts carbon dioxide, it changes its name again as carbaminohemoglobin. Carbaminohemoglobin. Carbaminohemoglobin is a hemoglobin molecule that has CO2 attached to it. I expect to see these terms in the future. They sound like I will ask them of you, which I will. The hemoglobin molecule also carries something called nitric oxide, and I'm going to make a big case for nitric oxide here. I've used it clinically. This is a gas that your body naturally makes as a result of inflammation, which some of you may have already known from A&P. If you have a tissue injury, let's say you roll your ankle, and remember how if you like roll or sprain something, it swells up? Well, one of the things that your body makes is nitric oxide. So this is something your body already makes, and we can artificially give it to a person too, but your body makes it, and then it allows, right, for nutrients and everything. It's an endothelium relaxer. In other words, it lets the blood vessels be more permeable to allow for more nutrients, oxygen, things like that to go to the tissues to help heal the tissues, right? It's a result of the inflammatory mediator cascade. So one of the things that we can actually give to a patient is artificial nitric. I can actually put it in line with their ventilator. I can put it in line with their breathing machine and actually give them nitric oxide to vasodilate their blood vessels. So that way there's more blood moving through the alveolar capillary space. Sorry, that's the wrong side. So I can vasodilate the red blood cells, their pulmonary capillaries. So now there's more blood volume going through their lung tissue. So that means I have a lot better ability to pick up oxygen because there's more red blood cells being exposed to oxygen. In other words, I can improve their oxygen levels if I vasodilate those blood cells in the lungs. Well, the cool thing about nitric is it's a topical thing. So if I give it through the breathing machine, I'm only affecting the pulmonary capillaries. I'm not affecting their systemic capillaries. So the capillaries that are in their fingers and their toes, they stay constricted, or they stay at their baseline state. But the ones in the lungs that are exposed to the nitric, well, they will relax. They will dilate and allow for more red blood cells, therefore more oxygen, makes it more permeable, right, for oxygen and better diffusion ultimately when we're looking at that. So nitric is something that also, right, hemoglobin also carries nitric, but it binds to the globin and not the iron. So what does that mean? That means it's not going to affect your saturation level. And as far as it's not going to take up that parking space. In other words, you can still bind 4 oxygen molecules there. But instead of it attaching itself, and that's why I have that previous screen where you've seen the protein chains all folded and stuff, it attaches itself to those protein chains, right? It binds to the globin proteins, not to the iron part. So you can still carry oxygen, and now you have this also that can be carried there as well. So your body's going to be very efficient here. So it's kind of a neat thing that your body naturally makes. And then for certain patients where we need to increase the amount of oxygen in their bloodstream, one of the tools that we can use is actually giving them artificial nitric oxide. Okay, throughout life, and I already previewed this, so, you're just going to have to excuse this, but remember, repetition is the key to learning. So at birth, if you guys do work neonatal intensive care, all those babies at birth have fetal hemoglobin, HGBF. About 4 to 6 months old, they'll start to gradually decline as they are now making adult hemoglobin. In other words, they are transitioning, their bone marrow, everything is transitioning from having a low oxygen environment to now having, a normal atmospheric extrauterine environment, if you will. So around 8 months of age, around 6 to 8 months of age here, it should be almost completely, not 100%, but almost completely adult hemoglobin, right? Gamma and beta alpha and beta instead of alpha and gamma, right? So that's what we're looking at here. So if we have a baby, right, and here's why I talk about this, not because it's adorable, although it is, it's also important when we're looking at things like sickle cell disease. Sickle cell disease usually won't show up until a kid is at least 4 to 6 months of age, because here they'll have mostly fetal hemoglobin that works really well. Remember, it's very efficient at carrying oxygen. And when we transition to HGBA, or alpha and beta, which is your HGBA, once we transition to adult hemoglobin, that's when you start to see the sickle cell anemia start to play a role. These kids get unusually tired, labile, very malaise, things like that. There's other things that can go along with this sickle cell anemia as well. But when we're looking at this, that's why we might see a delay in something like sickle cell anemia, because they have a different type of hemoglobin going on. Now let me ask you this. You have a baby that's given an adult blood transfusion because, let's say, the cord separated in utero, and that's why we had to deliver this baby early, or something like that where there was a lot of blood loss. Well, in this case, we can give them transfusion, adult transfusion. We can give them plasma. We can give them packed red blood cells. We can give them red blood cells. But when we give them red blood cells, usually it's from another adult, right? We don't have baby blood donors. So when we do that, we're actually giving them HGBA. We're giving them some adult hemoglobin as well. So just a couple things to have in the back of your mind if you do work in neonatal care or pediatric care. These are just fun facts. I like this type of stuff. Hemoglobin, believe it or not, can also be found in invertebrates like fungus and plants and all that stuff. That's what gives them their protein. Legumes, right? Good old legumes here. Legumes have their own hemoglobin called lagunohemoglobin. Isn't that funny? Legume hemoglobin. It looks for oxygen molecules instead of transporting them, so it does it a little differently. It scavenges and it doesn't transport. In other words, it holds on to them. And most of these plants are called nitrogen fixers. In other words, they help donate nitrogen that's in the air. Remember, the atmospheric gas is almost 80% nitrogen, right? And so they can actually gather that gas and use it for the plant. Now, like, let's say you're grass, right? There's green grass outside, depending on when you're listening to this, but if there's green grass, the grass cannot use the nitrogen that's in the atmospheric air, right? So that's why when you put fertilizer on your lawn or fertilizer on plants, that's giving them nitrogen mostly, right? That's that first number in the 3-number thing on the fertilizer. You're giving them that nitrogen because the atmospheric nitrogen is not in a form that those plants can recognize. Well, these plants actually can take atmospheric nitrogen, right, in the gaseous form there and use it. It's pretty cool. So that's ultimately how they use it, because they're nitrogen fixers and how they use the gas. They actually, the hemoglobin itself that helps them with their process, their own little metabolic process, if you will, gives them that higher protein content ultimately. So it's pretty interesting to sort of see how atmospheric gas and nitrogen fixers and all that stuff still works in other living things as well, and how we have such biodiversity and why it sort of can matter for some of those things. Now, I'm not expecting you to remember anything like this for the test. I just thought it was interesting material. All right, so what happens when gas ultimately competes for binding sites? So one of the gas that competes for binding sites in your bloodstream is carbon monoxide. So CO there stands for carbon monoxide. So this will compete for the same binding site as oxygen. And we already talked about carbon monoxide a little bit. So the trouble here is, and I want you to sort of cross this out. So EGANs, your hemoglobin molecule itself prefers carbon monoxide over oxygen. And the question here, and you have different sources, and you're going to love me for this, but just hold on. There's different sources. Your book that we're doing this class out of says hemoglobin prefers carbon monoxide 210 times more than oxygen. There's another book for mechanical ventilation that says this number, 240 to 250 times more. Your EGAN's book says hemoglobin prefers carbon monoxide by 200 times more, right? So when we're looking at this, I'm going to give you a range, roughly 200 to 250 times more preferential. So if you see this, I'll ask you the range. I'm not going to ask you for any of these individual numbers. So just make sure that you know the range that hemoglobin prefers carbon monoxide. But understand the concept here. If you have a hemoglobin molecule, and I'm not going to draw the whole thing, but if I have a hemoglobin molecule here, and then I have, let's go green for oxygen. I have an oxygen molecule that wants to bind to it, and then I have, let's go purple, a carbon monoxide molecule that wants to bind to it. If the hemoglobin sees this, one of these is much more attractive, and so therefore it's going to take up the binding sites on that molecule. So it thinks it's prettier. It thinks that it wants to be bonded to the carbon monoxide much more than oxygen. Boo, right? Sad times. Oxygen probably feeling all lonely now. Sad times, oxygen. There are other red blood cells that oxygen might find and bind to, and that's where we're going to have trouble, because we're going to have such low oxygen content overall that it's not going to want to dump itself to the tissues, and we'll talk about that when we talk about the dissociation curve. But when we're looking at carbon monoxide, it wants to take up all these parking spaces. It wants to bind itself, and the hemoglobin molecule is okay with that because the hemoglobin molecule loves that carbon monoxide. This is not good. And when carbon monoxide combines to the hemoglobin molecule, it's called carboxy hemoglobin. Now remember, CO2 that's bound to hemoglobin is called carbamino hemoglobin. And this is where I see some students sort of get this a little sideways. Carboxy means it's fighting for that hemoglobin site. That's why I think of boxing, right? It's fighting for that site. And if it's fighting for the site, that is carbon monoxide. That's carbon monoxide, right? If it's fighting for that site, carbon monoxide. So carboxyhemoglobin. So hopefully that helps out. Carboxyhemoglobin is fighting for the site. Carbamino is just CO2 attached to it. Other gases can also compete for hemoglobin as well. So when you're looking at CN, if you don't know what this is, good for you. But CN it's a long word, but it's ultimately something that's found in tear gas. So that's something that can actually bind or compete for the binding sites in your lungs. So hopefully you don't have personal experience or won't have personal experience with this, but let's say you work at a hospital and you have people that were, or patients that were exposed to tear gas. That is something that can compete for their site. So that's just one example of gas that can also compete for hemoglobin as well. So I'm not going to ask you too much about that, but just understand there are gases that also compete for the parking spaces of the hemoglobin, right? And so carbon monoxide is going to be one of your most dangerous ones that competes for those parking spaces, because once you have those parking spaces taken up by carbon monoxide, your ability to drop oxygen into your tissues decreases significantly, and you can end up going into system failure pretty easily. So the big one to look at here is the carboxyhemoglobin, or carbon monoxide, right? Carboxyhemoglobin is attached there, right? So we're not worried near as much about like nitric or tear gas or anything like that. Not as severe. In fact, with carbon monoxide poisoning, we already talked about in one of the Zoom meetings, with carbon monoxide poisoning, one of the ways to help with that patient is to give them as much FiO2 as possible, and we might even put them in a hyperbaric chamber. In other words, a chamber that we pressurize above atmospheric pressure. So normal, let's say Florida is 760, or at sea level 760. So we're going to put the atmospheric pressure higher than that, like we're diving into the ocean, so that way we can get even more oxygen diffused into the body. So that's Henry's law when we're ultimately looking at that. So it's going to be looking at different ways we can get that. In fact, I even had patients, I had 3 patients that came in last time I worked burn ICU. I had 3 patients that came in with carbon monoxide poisoning. They actually were flown to our facility, and 2 parents and a child. And one of the parent was diving with the child while we were waiting for the other parent to arrive. And so I had to give them oxygen. Actually, I had to give them room air, the baby room air at during the dive, so that way they didn't have oxidative injury, because remember, babies are actually more prone to oxidative injury. And so we were actually had to do this. I was actually calculating how much pressure there was and the gas laws in order to figure out how much room air to supply the baby, so the baby didn't have oxidative injury while they were being treated for carbon monoxide toxicity. Isn't that crazy? But it goes to show you all this information is not just random. We talk about this stuff for a point, and you may find these applications out there as a practicing therapist, unfortunately, but still you would have been exposed to this. So when we're talking about saturation, oxyhemoglobin is, remember, the term for when oxygen is bound to the hemoglobin molecule, so that's oxyhemoglobin. If the hemoglobin molecule does not have oxygen bound to it, it's called deoxyhemoglobin, and it's also called reduced. More of a chemical term, but reduced hemoglobin is just a synonym for deoxyhemoglobin, right? Different terms for the same thing, reduced or deoxyhemoglobin. So a couple things here with pulse oximetry, and that's where we can put that little finger probe on someone or on their ear or on their forehead, right? We can directly measure the amount saturated through an ABG, or we can indirectly measure it with a pulse oximeter. So what's important here is that you know that we can directly measure it with an arterial blood gas or indirectly measure it with a pulse oximeter. So when we directly measure it with a blood gas, that's where you, as the respiratory therapist, will go in and draw a sample of blood from their artery. When we do that, we'll run it through the machine, and the machine looks at their saturation on the hemoglobin molecule. It doesn't just use the light waves. We can also break it down to how much oxyhemoglobin, how much reduced hemoglobin, how much methemoglobin, how much so on and so forth. We can break it down to the different hemoglobin levels and get an accurate saturation. When we do send the blood gas, and we want to see each one of the hemoglobin levels, this is going to be what's called a co-oximetry. So this means if you have a patient, so let's give you a scenario. I always love scenarios. So let's say you mentally imagine wearing your stethoscope, you have your PEMA scrubs on, and a patient shows up to the emergency department with possible carbon monoxide poisoning. Well, if I put a pulse ox on their finger, right, if I just put one of these things on their finger, it will tell me how saturated their hemoglobin is. Now remember, will carbon monoxide bind to their hemoglobin? Absolutely. So their saturation will read very good. In fact, their saturation will read great. They'll read a very high oxygen saturation. In fact, it just reads a high saturation, which we assume is oxygen, right? It's just looking at bound versus unbound hemoglobin. And right now, this pulse oximeter, this little thing that goes on the finger, is saying, hey, the hemoglobin that's reflecting the light back to itself is bound. Well, it doesn't differentiate between bound and being oxygen and bound being carbon monoxide. So another way to do this, if you're concerned that they might have dysfunctional hemoglobin like carbon monoxide or carboxyhemoglobin, you would send the blood gas, you would draw a sample from their artery and send it to the lab for what's called co-oximetry. And I've done this as a professional, especially if I have patients on nitric, or if we have a patient that's doing poorly after a lidocaine treatment. That's something that we can do. We send it to the lab for co-oximetry. And what this one does is it looks at all the different hemoglobins. It looks at your methemoglobin, it looks at your carboxyhemoglobin, it looks at oxyhemoglobin, it looks at deoxyhemoglobin, it looks at all the different hemoglobin levels. And just like Dalton's law, it adds them up to a whole. And so I can actually see and directly measure how much hemoglobin is oxyhemoglobin. Right? So if you have a carbon monoxide patient and you send a blood gas, their saturation on their pulse ox looks great. But when you actually look at their saturation on co-oximetry, their saturation is going to be very poor. Right? I hope that sort of makes sense when we're looking at this. But the big thing here, we can directly measure and we can also indirectly measure, right? Indirectly is pulse oximetry. As long as someone does not have dysfunctional hemoglobin, this can work. All right. So this next part, I don't expect you to remember, but there is a machine out there, and I expect them to keep growing this technology, that can actually look at different wavelengths other than just bound and unbound. It can look at different wavelengths and look at co-oximetry using indirect measurement. The one, and we actually have it in our lab, it's that Rainbow 7. It's the it's a pulse oximeter that actually uses different lights to see what types of hemoglobin the patient has. So in theory, if you had one of these machines, so I'm just doing this, I don't get paid by that company. In fact, I'm not even mentioning the company's name. I did mention the name of the product though, so you can verify on your own time. But you could, in theory, have this patient come in with a questionable burn injury or carbon monoxide poisoning, and you could, instead of drawing a sample from the artery, in theory, you could just use this pulse oximeter that could tell you how much carboxyhemoglobin they have, right? So it's kind of cool that technology is getting better and better in that aspect as well. Still, the gold standard for this will be an arterial blood sample. Okay, so how does a pulse oximeter work, right? How do these like $30 things from Amazon work, right? So when we put this on your finger, it shoots out 2 wavelengths, so it uses photospectroscopy, something like that. My chemistry is a little rusty. Kind of funny, right? Because we're talking chemistry instead of rust. Anyway, so when we're looking in oxygen, right, rusty. Oxyhemoglobin has a wavelength of 660 nanometers, while deoxy or reduced hemoglobin has a wavelength of 940 nanometers. So when we shoot these wavelengths through there, right, we're going to use some lasers. We're going to shoot the shoot those wavelengths through the finger or wherever we got the pulse ox connected. And we're going to look at how much wavelengths are, we're going to look at the wavelengths. So depending on how much oxygen you have in your system, it's going to reflect or refract it back to the machine. The machine looks at the difference in the wavelengths and estimates this as your saturation level. So how well saturated your hemoglobin is with whatever gas could be on there, which we usually assume oxygen. So it uses the light reflection in the photospectrometry to look at how bound the hemoglobin is. So if you have a chemistry history, or you might have done these in some experiments in college or high school, or even middle school for some of you, where you actually shoot lights into stuff and you can actually tell what type of material it is by how the light reflects or refracts based upon it. And that's exactly how these work. It's looking at the light reflecting or refracting back and telling us how bound the hemoglobin is. So we're actually just using that same thing in real life. So what does that tell you? If someone's in a very, very bright space, if we're out in the middle of the bright sun, or if someone has a light shining on it, ambient light, that can be a factor in the accuracy of these things. And if someone has nail polish, right, really, really thick, dark nail polish, or really big artificial nails, we also might have an issue getting accuracy as well, bouncing through the nail bed there. So you got to sort of know your equipment too as a respiratory therapist, and not just the science behind it, because now that you know this, if you see someone's oxygen levels being abnormal, but they have these big fake nails on, or there's a lot of light reflecting on it, it's in a very bright area, then you know that those are all things that can factor into the accuracy, and therefore that may not be the most accurate numerical representation of what's going on.